this, we're taking 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 with a pinch of salt.
Dear ERA community, welcome on today's podcast, A Pinch of Salt, a comprehensive chat with eminent experts on various subjects that seem simple at first glance, but they aren't. I'm Dr. George Kosmadakis, your host for today's podcast, and I'm honored to have a chat with Professor Smeeta Sinha from Manchester, UK, who found some time in a very busy schedule for a discussion on vascular calcification and calciphylaxis. We're in the press room of the Congress Center in Stockholm. Outside, a lot of exciting things are happening, and we have the pleasure of a face-to-face discussion. Smeeta, thank you very much for being with us today.
Thank you for having me.
So, chronic kidney disease, metabolic bone disorders is a topic that has been talked about a lot, but with a limited number of available and efficient solutions. Vascular calcifications are always there. After 25 years of career in nephrology, I'm still amazed with the extent of vascular calcifications seen in the x-rays of the patients. And I feel a bit nihilist about that sometimes. In order to improve our knowledge on that, we have the pleasure to talk today with Professor Smeeta Sinha, an authority on this matter. Smeeta is a consultant nephrology at Salford Royal Hospital in Greater Manchester and a professor at the Manchester Academic Health Science Centre at the University of Manchester. Smeeta's research interests include chronic kidney disease, mineral bone disorder, in particular vascular calcification, glomerulonephritis, and rare kidney diseases. She is recognized international key opinion leader in the field of calciphylaxis, and despite the challenges of conducting research in the rare disease space, she has supported the development of clinical trials, including phase 1 to 3 studies. So, Smeeta, I will go straight away to the questions. Is vascular calcification associated with unfavorable clinical outcomes? Should I care?
Oh, you already know the answer to that. It's true, isn't it? It's everywhere, and you described it earlier in your introduction. 25 years of nephrology, and you see it in all our patients. And we know that vascular calcification is present at CKD before people start dialysis. It's a high prevalence at incident dialysis, and it gets worse. So I think the report that's usually cited is the 83% prevalent vascular calcification on hemodialysis, which is big. The question is that what's causing the cardiovascular adverse events that we see? And the answer is probably yes. The challenge has been in, can we modulate that? Can we change it? Does it improve outcomes? I'm not so sure that we've been able to find an intervention, but hopefully we'll start to see more trials emerging that will show whether modifying vascular calcification, measuring the tools that we have now, actually make a difference to patient outcomes. So I think the answer is yes. I just can't prove it yet.
Right. So we have a very important impression that vascular calcification is associated with cardiovascular outcomes. Okay.
Yeah, absolutely. And we know that the more calcification you have, the more likely you are to die, and cardiovascular events and or cause mortality.
So there is a direct clinical association, we could say, but are there any developments concerning the metabolic pathways of vascular calcifications, and are there any biological mechanisms identified that associate the two procedures?
Yeah, so I think our understanding of vascular calcification has improved massively over the last 20 years. So previously, we used to think it's just calcium and phosphate depositing in the blood vessels causing calcification, but now we know there are so many factors. There's a very close relationship between the bone and the vascular access. So not in kidney patients, but we know that if you have osteoporosis, there's more calcification. So there are links between bone and kidney, and we're seeing that in our patients. We're also seeing more about inflammation coming through as well, hyperparathyroidism as well. So I think we understand more about vascular calcification naturally and inhibitors and promoters, but we don't still have a drug or a therapeutic target. We have a target, but we don't have a therapeutic intervention that's shown to improve things yet.
Which are the targets?
So many. And I think that's something that perhaps we've just focused on one. So we've thought about phosphate. Yes. If we lower phosphate, will we improve cardiovascular outcomes? And we've seen, in the early 2000s, maybe those studies didn't show that. Then we thought, okay, what about if we control PTH? So with cinacalcet, I know the study was negative, but actually when you look at the data, maybe there is some benefit there that wasn't borne out in the trials on vascular health. So that's looking at individual targets, but maybe we need to think more holistically and target multiple avenues. We've looked at vitamin K, so I don't know how we pull it all together. Maybe we need to look at the end point, the actual calcification bit, rather than individual pieces, or maybe we need to look at inflammation in more detail, because we haven't really looked at that as much as trying to manage the kidney things, PTH, phosphate, the things we're familiar with. We're less familiar with.
We're two nephrologists.
Yeah, we like to mess around with dialysis, right. But maybe we need to think a little bit differently. And I think, exactly. And I think inflammation is something there, or the end pathway, the end product. How do we stop hydroxyapatite propagation and formation?
So I think you answered to this question, but concerning the promising treatment options of the vascular calcification, so you think you should dissect the problem and the risk factors and start treating each one of them individually?
Yeah, I think it's hard, isn't it? For a period, we've stopped doing the studies. So there was probably about 10, 15 years ago, we were doing the phosphate studies, we were doing the PTH studies, and then there was a bit of a gap. So the good thing is interest is emerging again, and we're seeing people do studies on high phosphate, low phosphate. We're seeing people find novel new therapies like the SNF472 drug for calciphylaxis, but there are other companies that are also developing their products. We're also looking at multiple interventions. So I'm referencing calciphylaxis, but the principle is the same. The BEAT Calci study looks at not just one thing, it looks at vitamin K, sodium thiosulfate, magnesium, and the dialysis membrane in one study. So it may even tell us what combination is most effective. So I think we need to, yes, look at new drugs, but also look at potential combinations in the same patients using novel and more pragmatic trial designs, but look at everything.
You have mentioned some of these. I have seen studies with vitamin D analogs, with cinacalcet eventually, magnesium, vitamin K, that is also one of the treatment options for calciphylaxis. Are all these tools have been studied for the vascular calcifications, or we just don't know?
So some of them have. So there's been quite a lot of interest in vitamin K in vascular calcification. So we've had a few studies looking at vitamin K effects on vascular calcification. And they have been mixed, I think is fair to say. And I think the view is that vitamin K supplementation does not impact vascular calcification and outcomes. But that doesn't necessarily mean the same will be for calciphylaxis, which is a more severe form of vascular calcification. So I would say to people, why don't you test your theories and your drugs in people with calciphylaxis first? They're more desperate, but they have more events. So you may be able to see whether your intervention has a beneficial effect on calcification, vascular calcification, and then you could maybe take that to end-stage kidney disease-associated vascular calcification in general. But yeah, vitamin K I think has definitely been a mixed picture in coronary artery calcification, aortic calcification, but some promise in calciphylaxis.
Well, you see these X-rays, horrible X-rays, and you ask yourself whether there is an interest to search for it if you don't have any solution to offer. Is there any interest to search for it? or is there any interest to see the evolution of the calcification of your patients from one time point to another if there is no specific option? Then these are very tangible questions. So you advise us to take each eminent risk factor individually and try to treat it and hope for the best.
I think we have to look at the patient in front of us and do our best. And every patient is slightly different. Yeah. They may have calcification as a result of sort of atherosclerosis associated calcification, which we typically see in the intima, or they may have more typical medial calcification, which you see in diabetics and people with end-stage kidney disease. So for your atherosclerotic patient, you're still going to do the cholesterol, no smoking, all those things. And with maybe the CKD MBD phenotype, you may go more aggressively at the bone mineral metabolism markers. I think it's very difficult, and I think that's why we haven't got a solution. But our knowledge is increasing so rapidly. Hopefully our trial designs will enable us to answer the more difficult questions, where we've previously tried one target, one drug, one target, one drug. That's not really worked for us in this field. So we need a different way of looking at it.
Do you want to risk a view on the future and tell me, based on the trials that are underway today, which are the potential therapeutic targets, and which are the potential pathophysiological mechanisms that are studied actually?
Yeah, I mean, I don't know all the drugs that are developing, but the one that I'm most familiar with is the SNF472 drug. So that has had some interesting trial data come out of the Calciphylaxis study. So the primary endpoints were negative, which was wound and pain. But the safety signals, if you can call them signals, they're not even signals. Basically, in the safety evaluation, there were fewer deaths and CUA-related hospitalization. So they're important for a patient. So, maybe there's something there we need to look at. If we're looking at coronary artery calcification, aortic calcification, valvular calcification, they're not like calciphylaxis where they're going to die. So we need to make sure that we're not missing any safety signals from a bone perspective as well. So I think people will want to look at these novel drugs to see, yes, do they affect calcification, but also do they improve death, cardiovascular events, and is there any negative impact on bone health? So I think the SNF472 one looks promising, and hopefully they will continue to do more studies. But I would also not give up on the multimodal approach. So trying things that maybe, if you just look at it in isolation, haven't been effective or haven't been shown, like vitamin K. Maybe if it's in combination with other things, then it might be of value. So I think this is where the platform trials are helpful, where you can try combinations
Clusters
of things.
And
I think that's what will happen in the future. Yeah. We will try and mix and match and look at how we manage diseases, but also the drugs for those diseases.
Perfect. Thank you very much. And I will pass on to the other entity that would like to discuss today with you. Is calciphylaxis. You are a world leader on this, and you have talked about this trial, SNF 721. But what is calciphylaxis?
Yeah, I will always find a way of talking about calciphylaxis, even when you ask me about vascular calcification, because it is vascular calcification. Calciphylaxis is a type of vascular calcification, except that calcification happens in the small blood vessels in the skin, so in the arterioles. So when those vessels are so small, if you calcify those, then you get proliferation and then you get fibrosis, but you also get thrombosis. And if you thrombose one of those small vessels, you're going to get ischemia, you're going to get necrosis, and that's where you see the big ulcers, and they're painful. Tissue ischemia, you're suffocating the skin of oxygen, it's going to be painful. So you see painful ulcers that can appear very quickly. They can get infected, but they break down so much and cause so much pain. Some people need amputation, but the mortality is 45 to 80%, depending on which report you look at. In our study, only 17% of wounds healed. Our mortality was over 50%, and median survival was 4 months. So calciphylaxis is a devastating form of vascular calcification with high mortality and no proven treatments. So that's calciphylaxis.
It is a very rare complication, but those of us who had personal experience with this, they cannot forget it. And for all these rare diseases, I always remember a patient with a rare disease who told me, "Doctor, you are talking to me about this rare disease, but me, I got it 100%. You have to treat me."
That's a really good way of looking at it. I'm going to use that. Thank you.
You're welcome. So, how should I treat calciphylaxis?
Yeah, so I actually can't tell you exactly how to treat it because we haven't done the studies. What I will say is that we're now doing the studies and there are clinical trials available in some countries, not all countries. So if you have a country where you've got a trial, encourage your patient to go into the trial. If you don't have a trial, then try and bring a trial to your country and we can help. And if you don't have a trial, then all you can do is try and manage the patient in front of you. And we all try and do our best. So have a look at some of those risk factors and what you can try and address. But the reality is it's opinion-based. You can't guarantee to the patient that this is the treatment. So you have to be honest to the patient. And I would say the single most important thing you can do in that setting is be truthful and tell the patient that the chances are that despite everything we try, they may not survive. So you can focus on wound care. They can also get their plans in place, say goodbye to their loved ones in time.
And thiosulfate, sodium?
So there's been a really nice meta-analysis that was published last year now, I think, which looked at STS as a therapy. Meta-analysis again, and a lot of the data was looking at retrospective data or large registries. And their conclusion was that there was no evidence that STS confers benefit. So there isn't anything that says that this leads to wound improvement. Right. But again, the studies that it was based on, they weren't randomized controlled trials. There has never been a randomized controlled trial in STS. So I don't think we have the evidence to say it works, but I also think we don't have the evidence to say it doesn't work.
It doesn't work.
Yeah, so I wouldn't want to say it's rubbish, never use it. But what I would say is study it in a clinical trial. And we do have a clinical trial that is answering that question. And that's the BEAT Calci trial that is currently running in Australia.
Right.
And they are hoping to bring that trial to other parts of the world. So I think with established treatments that we use, we can now test, or established treatments or treatments that people use, we can test those treatments in a trial setting. And then the new drugs that are coming out, then they can still go through the traditional randomized controlled trial setup.
There is a randomized controlled trial in France testing rheophoresis for these conditions. It's underway. We'll see.
And I fully endorse that approach. I think if you have an idea, if there's biological plausibility or equipoise, excellent, let's do the trial. And if it works, wonderful, we've got a treatment.
It is randomized. They do sham sessions of rheophoresis to some patients. It's very interesting. Perfect. So I think we'll get now to the more personal questions. And what about the stuff that you would take with you in a desert island? Which book, luxury item, and 2 songs?
Okay, so the book that I take, I'm a nephrologist, so this probably explains it, is Katsuo Ishiguro wrote a book called Never Let Me Go, and it's a dystopian world. I won't give away all of it, but there is a strong organ donation theme, or I'll give a little bit of it away, but basically there are groups. Just to start, there are groups of people who are essentially organ donors. That's their role in life. Oh. So it talks about the ethics around that. It is very dystopian, but he writes beautifully. So I'd recommend any of his books, but Never Let Me Go is one that I think a nephrologist should read.
Well, I think I would write a pig farm concerning the donors with what we see lately.
Indeed.
Which would not be very dystopian. Luxury item.
Okay, for the desert island. So I don't like being uncomfortable in bad weather. So if this desert island is a hot desert island, then I want a tent.
Right,
so I can stay away from the wind and the sun. If it's a cold desert island, I would like an electric blanket with solar panels.
Wonderful. There was a guest who asked for a pillow.
Oh no, you have to be practical.
And what about the two songs?
So the first song is called One Day Like This, and it's by a band called Elbow, like elbow.
Okay.
And they're from Bury, which is my hometown in Manchester. But their album was amazing, and the last song at my wedding was One Day Like This. It's a really good feel good song, and when the sun's shining, it works.
Wonderful.
So it would be a good song for today.
For today, yes. Here it's hot in Stockholm. And the second one?
The second one is Britney Spears.
Yes.
Oops, I did it again. It was not a lot. I was a junior doctor, and it's hard being a junior doctor. You work nights, and that song just used to make me laugh. And I remember one day on a Saturday, it was afternoon, I finished nights, so I decided to have some drinks early, and I was in the pub and sung it really loud, and that's how I met my husband.
Oh, so you did it again, but just once. Just a bonus question: Manchester United or Manchester City?
Neither. My husband is a Liverpool fan, so
in
I'm
Manchester.
Yes, I know. So I'm not allowed to.
This is a high treason, no?
Indeed, yes. So I will pass on the football question.
Well, I'm Manchester City.
But you've had a good year, good 4 years.
Yeah. Well, dear colleagues, I hope you enjoyed this very productive discussion as much as I did. It was like an anti-calcification psychotherapy session for the hopeless nephrologist. Things are happening. Things are going really fast. Probably next year we talk, with another edge, all this stuff. But we had the luck today to be with a committed specialist on the field. Smeeta, thank you for sharing your experience and this optimism and sight with us today. Dear friends, stay tuned for more exciting podcasts on various interesting subjects. 3 podcasts are broadcasted every month in the main social media platforms. Check us out.